Good morning, my dear friends. My name is Dr. Madan Narayanan. I am a consultant anesthetist from Frimley Park Hospital in the United Kingdom. Today, I will be talking on hygienic standards and infection control in regional anesthesia. Regional anesthesia is full of key debates. Should we be wearing sterile gloves and sterile gowns for single shot blocks? Should we have hand scrub with iodine, chlorhexidine, or soap and water is enough? What type of skin preparation should we use for the patient? How should we protect our probes? What type of gels to use? How to clean your probes after the procedures? And is local infection a contraindication to peripheral nerve block techniques? Should we use perioperative antibiotics to reduce catheter-related infections? Do local anesthetics have bacteriostatic properties? And does perineural infection cause long-term nerve damage? So we are filled with more questions than what we know. Let's see what the expert groups have to say about this and what the evidence recommends. So first to go on is the rate of peripheral nerve block infections for single shot blocks or catheters and how do they compare with neuraxial techniques. The largest database that we have is the data from the United Kingdom, which is called the National Audit 3 project or the NAP 3 project, which looked at major complications of central neuraxial block in the UK. From this, what was identified was the rate of catastrophic complications following spinal or epidural injections is between 1 in 23 to 1 in 50,000. And the incidence of paraplegia or death is 1 in 54 to 1 in 141,000. The incidence of infective complications such as epidural abscess is 2 in 100,000 and it causing permanent harm from the abscess is half of it, which is 1 in 100,000 and the incidence of permanent paraplegia is 0.4 in 100,000. So the incidence of complications or infective complications from central neuraxial techniques is very rare. How does this compare with peripheral nerve block techniques or nerve catheter techniques? Perineural catheter infection is again rare, but is more common than central neuraxial infections. They are in the order of 0 to 3%. The rate of catheter colonization is much more frequent. It ranges between 6 to 57%. The commonest organisms that are identified are Staphylococcus epidermidis, and if there is an abscess formation, then Staphylococcus aureus. The commonest risk factors in these patients are they are either trauma victims, intensive care unit patients, or they have immunodeficiency or diabetes. They have postoperative hyperglycemia, which is uncontrolled. Absence of antibiotic prophylaxis is a risk factor, and catheters lasting more than 48 hours are a significant risk for infection. What technique should we follow? Should we follow full asepsis with mask, surgical gown, or single shot or peripheral catheters? How does this compare with peripheral nerve blocks versus neuraxial techniques? The first recommendation for face mask came after clustered infections where the oral commensals of the practitioner, such as a neurologist or a neurosurgeon, or the anesthesiologist who were performing neuraxial procedures, they contributed to the development of meningitis in a few cluster of patients. Subsequently, the American Society of Anesthesiologists, Center for Disease Control, and the Association of Anesthetists, AAGBI from the UK, recommend using of face mask for invasive procedures. Again, there are a lot of extrapolations from surgical site infections as it is unethical to perform clinical studies. The NAP 3 audit, when it looked at the patients who developed infections, when they looked through areas of substandard care, they identified 5 patients who developed infections. The anesthesiologist was not wearing a face mask. So when it relies on defensive practice, it is very important to follow full aseptic techniques. How does the practice of asepsis differ between different countries? In the United Kingdom, full aseptic precautions include a sterile surgical gown, sterile gloves, surgical hat, face mask, whereas in the United States, just aseptic precautions are followed for performance of peripheral nerve blocks, catheters, or even neuraxial techniques. The Association of Anaesthetists guidelines from the UK definitely recommend optimal aseptic technique before performing central neuraxial blocks that require thorough hand washing with surgical scrub solutions, use of barrier precautions, including cap, mask, gown, and gloves, and the use of a large sterile drape. These practices are not consistent and are not recommendations from other societies, and this is where heterogeneous practice happens. The Australian Society recommend full aseptic precautions and use of sterile gown. The AAGBI recommend sterile gowns in 2008, but subsequently they have withdrawn it from the 2020 guidelines. The ASRA and the ESRA certainly recommend the use of sterile gowns for neuraxial anesthesia in pediatric patients, but they only mention aseptic techniques in adult patients, which does not mandate the use of sterile surgical gowns. Is there evidence to suggest that wearing a surgical gown or a sterile gown reduces the rate of neuraxial infections? In this study, which looked at the labor epidural patients and the rate of catheter colonization, there were no significant differences in catheter tip colonization between the doctors who were ungowned versus the gowned group. The ASRA Practice Advisory identifies that literature is insufficient regarding the use of aseptic techniques, such as removal of jewelry, hand washing, wearing caps, masks, and sterile gloves in reducing infective complications. But when a survey was performed to ask the ASA experts and the members, they all strongly agree that aseptic techniques should be used, but they were equivocal regarding the wearing of gowns. In this study, which was a survey of obstetric anesthetists from Australia, wearing of rings was common practice, and even having own normal clothes was common practice when prior to performing epidural catheter techniques. There was a heterogeneous uh, practice regarding hand washing, use of the type of screen preparation, and whether surgical drapes were used or not during performance of obstetric, epidural, or neuraxial techniques. Use of surgical gowns is not without its problems. The impact of neuraxial techniques on reducing the carbon footprint in this study, which looked at the carbon footprint of general anesthesia versus spinal anesthesia versus combined general plus spinal, it showed that the carbon footprint of spinal anesthesia is as equal as that of general anesthesia. The main reasons behind that is the use of electricity for cleaning and cleaning reusables such as plastics and gowns. So taking away the use of gowns is the only way to reduce the carbon footprint of neuraxial anesthesia. Is there any difference in the choice of antiseptic, which is used for neuraxial and peripheral nerve blocks? Both chlorhexidine and povidone iodine are equally effective. They have a broad spectrum, whereas chlorhexidine has a faster onset, retains its efficacy in presence of blood. It has a longer duration of residual activity, up to 24 hours, and it produces a lower incidence of skin reactions. Both chlorhexidine and povidone iodine are present in an aqueous and an alcoholic form. The alcoholic form is suspended in 70% isopropyl alcohol, which has additional antimicrobial properties. When chlorhexidine was compared with povidone iodine, the greatest data and recommendations is from reduction in surgical site infections. And the extrapolation to neuraxial techniques is from these data. So in this study, which looked at chlorhexidine versus povidone iodine to reduce surgical site antisepsis, the surgical site infections were significantly lower in the chlorhexidine group than in the povidone iodine group, both for superficial and deep infections. So subsequent to the publication of this data, the EPIC guidelines, which is using of chlorhexidine in vascular access, the NICE guidelines, and also the WHO guidelines recommended use of chlorhexidine for all antiseptic procedures. Is there any data on its reduction in infections? So in this study on epidural catheter colonization in pediatric patients, where chlorhexidine was compared to povidone iodine, the patients who had chlorhexidine 0.5% for skin preparation showed only a 1/6 the rate of colonization, and they were less likely to be colonized on the catheters when compared where skin preparation was done with povidone iodine. So there is direct data in pediatric patients to suggest the rate of catheter colonization is much lower with the use of chlorhexidine as compared to povidone iodine. Whereas in perineural catheters, in this study, which is the CLOVEP trial, which looked at chlorhexidine versus povidone iodine, both were associated with a low incidence of catheter colonization, even though the 2% chlorhexidine, which was the more potent form of chlorhexidine, was associated with a lower incidence. There were no catheter-related adverse infections or adverse effect on the skin with either of these group. So the main risk factor for the rate of colonization was a duration of catheter use more than 3 days and obesity. So the American Practice Advisory from the ASRA say that there is no difference in the rate of positive bacteriological cultures or catheter tip or on the injection site. There's no difference when alcoholic solutions were compared with aqueous solutions as well. And the findings of many other RCTs were very inconsistent. So when a survey was performed, discussing this with the experts preference was for chlorhexidine, whereas the ASA members did not have a clear preference whether chlorhexidine or povidone should be used. So in this landmark ruling, which came from the UK as well as from Australia, where chlorhexidine contamination on a patient who had a labor epidural caused significant adhesive arachnoiditis and paraplegia. And this led to the removal of these containers, which were used to clean the patient with chlorhexidine. And subsequently also chlorhexidine were tinted with pink color so that the chlorhexidine could be easily identified from the local anesthetic solution. So since then, it made a landmark change in the practice of how we identify chlorhexidine and reduction in contamination of chlorhexidine of the syringes. How should we dispense chlorhexidine? Should we be using multi-dose sprays, single-use sachets, or 2% chlorhexidine sponges? So when chlorhexidine used as multi-dose applicators, a single application, a single spray versus two sprays were done, and they were compared with skin colonization. No growth occurred in any of the plates after the first spray or the second spray. So use of a single spray of chlorhexidine solution is sufficient to disinfect the skin before regional anesthesia. A single spray means a single application of chlorhexidine and then allowed to dry. When multi-use sprays were compared with single-use sachets for neuraxial block in cesarean section, both techniques were effective in reducing the skin colonization. There was no difference in the effectiveness at epidural catheter removal. The time to achieve skin preparation was significantly reduced in the spray group compared to the sachet group, where it takes a longer time to dry. The spray cost was much cheaper compared to the sachets. In the ASRA practice advisory, they do identify that literature is insufficient, but observational studies do report that there is no microbial contamination when unopened multi-dose vials of chlorhexidine or povidone iodine are used compared to the sachets. When the experts were asked for their opinion, the experts as well as the members agreed that single-use sachets should be preferred or used in preference to multi-dose vials. Whereas in the UK, the multi-dose sprays are commonly used and not the single-use sachets. How long does it take chlorhexidine to dry on the skin? So in this study, which looked at the drying time of chloroprep before neuraxial anesthesia prior to cesarean delivery, in this observational study, the mean time to dry was 123 seconds, and it ranged between 85 to 195 seconds. The standard manufacturer recommendation is to allow it to dry for 3 minutes. And from this study, it was observed that you need to wait more than 3 minutes for the chlorhexidine to effectively dry before performing a neuraxial technique. What concentration of chlorhexidine should be used for neuraxial procedures and for peripheral nerve blocks? Should we use 0.5% versus 2%? The manufacturer of chlorhexidine strongly recommends against use of 2% near the meninges or the neuraxis. There is no evidence of superiority of 2% versus 0.5%. The risks in peripheral nerve blocks are unclear, but the risks are even lower. So the experts from the UK all have the opinion, though there is poor level of evidence to support 0.5% chlorhexidine versus 2% chlorhexidine, the chances of complications or neuraxial adhesive arachnoiditis could be lower with the use of 0.5%, and hence in the UK it is recommended to use 0.5% chlorhexidine in the neuraxis. The Association of Anesthetists, the AAGBI guidelines recommend meticulously taking time and meticulously preventing chlorhexidine from contaminating the needle or the gloves of the practitioner. So chlorhexidine should be kept well away from the drugs and equipment, and sufficient time should be allowed for the chlorhexidine to dry before the skin puncture with the spinal needle is performed. This prevents the transfer of chlorhexidine into the CSF and subsequently causing neuraxial damage. So the working party also considers it is reasonable to recommend 0.5% chlorhexidine to be used for both neuraxis as well as for peripheral nerve blocks. In this survey on Irish practice across all the obstetric units, identified that nearly 21% of the obstetric units use 2% chlorhexidine despite the manufacturer's recommendation against its use in the neuraxis. So local practices tend to vary, and there is still significant use of 2% chlorhexidine near the neuraxis. The argument is the chlorhexidine has been implicated in devastating neurological injuries, but there is insufficient evidence to suggest that 2% uh, can cause more harm, or 0.5% chlorhexidine is more safer. So what is emphasized is meticulous application technique, and time to dry is more important than the concentration of the solution. So what about contamination of equipment? How can we reduce the incidence of transmission of infection from equipment? So we are aware of this flow chart where sterile equipment require critical sterilization, whereas any contact with mucous membranes or non-intact skin require high-level disinfection, whereas when there is contact with intact skin, such as diagnostic procedures with ultrasound, we only need low-level disinfection. So the recommendations from the UK and the Europe all suggest that if the probe is in contact with mucous membranes or non-intact skin, high-level disinfection should be performed against bacteria, viruses, fungus, and spores. The Association of Ultrasound in Medicine, these guidelines are very clear. For any internal procedures such as transvaginal or transrectal examination, there should be use of a single-use probe cover and a sterile gel, or intraoperative use of ultrasound or transesophageal echocardiography. All the probes should have a cover, and they should be sent for high-level disinfection. Whereas when there is interventional percutaneous procedures where there is needle placement or percutaneous biopsies, in addition to use of sterile cover and gel, these probes only need low-level disinfection. And if the probes are in contact with intact skin, then non-sterile gel can be used, and only low-level disinfection needs to be performed. So follow manufacturer recommendations for how to clean the probe. Low-level disinfections use either ethyl or isopropyl alcohol or quaternary ammonium agents, and they are effective against most bacteria, viruses, and some fungi, and they do not have effect on mycobacterium or spores. High-level disinfectant causes destruction of all microorganisms except bacterial spores, and the commonly used agents are glutaraldehyde, hydrogen peroxide, or hypochlorite solutions like bleach. How to reduce transmission from equipment? Varying probe covers are used. Some probe covers, like sterile probe covers, or some probe covers where ultrasound latex condoms, or tegaderm, which are sterile, semi-permeable membranes are used. But the main thing to note is whatever probe cover is used, the pore size should be less than 30 nanometer to prevent transmission of most viruses. So in this large retrospective data from Toronto Western General, where they use a three-step process where chlorhexidine or povidone is used for skin asepsis, a tegaderm or transparent semi-permeable dressing is used on the ultrasound for probe for protection, and after the procedure is performed, they are cleaned with a low-level disinfection. In around 9,000 cases of single-shot peripheral neuraxial blocks, no case of infection of the patient was noted. So in conclusion, the rate of block-related infections following ultrasound-guided single peripheral nerve blocks is very practical and efficient using low-level disinfection techniques and a barrier dressing, and the risks are very low. Similarly, in this study, which was done from Australia, physically cleaning the ultrasound probe and then spraying and wiping with 70% isopropyl alcohol, and then the machine was passively air dried. No pathogenic organisms were grown from any of the collected swabs from the ultrasound probes or the machines. And in 85% of there were no cultures detected. And of the remaining 15%, it was either environmental organisms or common skin commensals were found on the machines. So they suggest that a simple decontamination protocol is effective and it can be implemented for single shot peripheral nerve blocks. What should be the coupling medium that tends to be used? Should we use reusable gel or sterile sachets? So what is recommended is for diagnostic procedures and intact skin, use of multi-dose vials is acceptable. But when invasive procedures, non-intact skin, mucous membranes, or immunocompromised patients are there, then sterile jelly should be used as the ultrasound coupling medium. There have been case reports or outbreaks of Acinetobacter or Burkholderia from use of multi-dose ultrasound jellies, which caused significant morbidity and outbreaks in the intensive care unit. So the best practice is to use smaller multi-dose vials and to have them only for before their expiry period. So and to not use out of date multi-dose vials. So does the technique of neuraxial choice, whether it's epidural or a spinal, impact infection rates? There was no significant difference in bacterial contamination of needles when lumbar epidural was done or compared with a lumbar spinal puncture. Similarly, the site of an lumbar epidural did not change the catheter-related infection or colonization rates. Lumbar epidural techniques were as safe as thoracic epidural techniques in terms of catheter-related colonization. What about the bacteriostatic effects of local anesthetics? Local anesthetics have been known to be bacteriostatic, starting from lignocaine to bupivacaine, among multiple organisms ranging from Staph aureus to E. coli, from gram-positive to gram-negative bacteria. Local anesthetics have demonstrated in vitro bacteriostatic properties. So greater concentration, longer exposure, higher temperatures all correlate with proportional increase in microbicidal activity or inhibition activity. Multiple local anesthetics at concentrations used in typical clinical settings, such as 0.125% to 0.75 bupivacaine and 1 to 3% lidocaine, have been shown to inhibit the growth of numerous bacteria and fungi. Bupivacaine and lidocaine inhibit growth of a significantly higher degree than ropivacaine. So in this clinical study, which looked at surgical wound site infection when comparing rectus sheath block versus thoracic epidurals, showed that the rate of wound infections is very low with either of these techniques when local anesthetics are infused close to the incision site. But the probability of infection with single shot blocks varies with the site of the block. In this meta-analysis, where parasternal intercostal block during cardiac surgery was used, it showed a significant reduction in wound pain and a reduction in hospital stay, with a slightly increased risk of wound infection with an odds ratio of 5. But however, the significance was not statistically important. So what they recommended was decisions regarding adoption of new regional techniques should be made in conjunction with the relevant surgeons when the injection point is close to surgical areas. How about prophylactic antibiotic therapy prior to performance of neuraxial catheters or peripheral nerve catheters? So the ASA practice advisory identifies that literature is insufficient to recommend use of prophylactic antibiotic in suspected bacteremic patients to reduce the risk of infective complications following neuraxial techniques. But when a survey was done with the experts and the ASA members, they both strongly agreed that when a neuraxial technique is preferred in a suspected bacteremic patient, pre-procedure antibiotic should be recommended or administered, even though there is no evidence to support the use. For peripheral nerve or fascial plane blocks, local contamination is not an absolute contraindication to performance of fascial plane blocks, unlike neuraxial techniques. For example, rectus sheath blocks or catheters are perfectly safe in patients with septic peritonitis. Use of sterile occlusive dressings at the catheter insertion sites. There are no comparative studies which were found that indicate whether the use of sterile occlusive dressings reduce the rate of catheter-related infections. Observational studies suggest that positive cultures may still occur when sterile occlusive dressings are used. So when a survey was performed on the ASA experts and the members, they all strongly agree that sterile occlusive dressings should be used at catheter insertion sites. Does the use of a bacterial filter reduce the rate of complications? So the practice advisory identified that there were no comparative studies that found whether the use of a bacterial filter reduces infective complications. There is low quality evidence, but it does not reduce distal positive cultures, and bacterial colonization still occurs. But when the survey was performed, the experts are uncertain regarding the use of bacterial filters in reducing catheter tip colonization in epidural infusions. What happens when a catheter is accidentally disconnected? Should we reconnect them? What could be the infective complications? The practice advisory identifies that literature is insufficient to evaluate whether limiting disconnection or reconnection are associated with reduced frequency of infections. But the survey performed showed that the experts and ASA members strongly agree that disconnection and reconnection should be limited to reduce the infections. But they also identified that if the catheter is accidentally disconnected, it is not necessary to remove the catheter. So the literature is insufficient whether removal of an accidentally disconnected catheter is associated with a reduced frequency of infections. ASA members are equivocal and the consultants disagree that the catheters should be removed when there is an accidental disconnection. But if it is identified that it's an unwitnessed disconnection and where the duration of disconnection is uncertain, then the catheters should be removed. There is even weaker evidence for tunneling, use of semi-permeable dressings, or chlorhexidine impregnated patch to reduce infective complications in peripheral nerve catheters. So there's no strong recommendation, even though when these techniques are combined with other measures, the total rate of infective complications will be far lesser. Limiting the duration of catheterization. So many observational studies have identified an association with longer duration of catheters with greater incidence of infections, but no literature was identified for a specific duration to a specific rate of or a percentage of infection. So all the members agree that catheters should not remain in situ longer than when clinically necessary, where the risk benefits are altered. So, in summary, before performing neuraxial techniques, uh, you need to identify if the patient's got a history and a physical examination that will contraindicate them to a higher risk of infective complications. Consider alternatives to neuraxial techniques at patients with high risk of infective complications. When neuraxial techniques are selected in a known or a suspected bacteremic patient, consider pre-procedure antibiotics. Select neuraxial techniques on a case-by-case basis and avoid lumbar puncture in patients with a known epidural abscess. So this was the summary of the practice guidance. And they recommend use of aseptic techniques during preparation of any equipment, and which includes hand washing and use of caps and masks and sterile gloves. So use of individual packets of antiseptic for skin preparation and use chlorhexidine for skin preparation and allow sufficient drying time. And they also recommend using sterile occlusive dressings at the catheter site. Bacterial filters may be considered, especially when the infusion is for a prolonged period. Limit the disconnection and reconnection of epidural catheters to reduce infective complications, and remove the catheters if there is an unwitnessed, accidentally disconnected catheter. And catheters should be removed at the earliest possible opportunity and should not be left for longer than necessary, especially beyond 48 hours. If you stay along with your peers, you would not be wrong. I thank you very much for your attention.